Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through some questions with you guys to help you on a journey to a 250. We are starting our renal pharmacology sessions, and this video we will be mostly discussing upon the basics of renal pharmacology and drug excretion. So, talking about the quick review, okay, there is a filtration in the glomerulus where the blood flows into the kidneys, and within each kidney there are tiny structures called as nephrons. The glomerulus is a network of capillaries within the nephron and filters the blood to form a fluid which is called as filtrate. And after that, there is the reabsorption in the tubules. So as the filtrate moves through the renal tubules, essential substances like water, electrolytes, and nutrients are reabsorbed back into the bloodstream. Now, this process ensures that important components are retained in the body. Then again, there is the secretion. So some drugs and waste products are actively transported from the bloodstream into the renal tubules. Now, this is known as secretion and is a crucial step in eliminating harmful substances from the body. So formation of urine. So the remaining fluid in the tubules now is called as urine, consists of waste products, excess ions, and water. Now this urine flows through the collecting ducts and into the renal pelvis, eventually exiting the body through the ureters. Many drugs undergo filtration, reabsorption, and secretion in the renal system. The efficiency of drug elimination depends on factors such as the drug's molecular size, charge, and lipid solubility. Now, some drugs are actively secreted into the urine, facilitating their removal from the body. Then there is the something concept called as renal blood flow regulation. So the kidney help regulate the renal blood pressure and electrolyte balance, which can impact the drug distribution and elimination. Changes in this renal blood flow can influence the pharmacokinetics of the drugs. So the renal system maintains a delicate balance of electrolytes, water, and acid-base levels in the body. Now, this balance is essential for overall physiological functioning and can affect the efficacy and safety of drugs. So here we have one question. So how would the renal excretion of the antihypertensive drug most likely be affected? So we have a 50-year-old woman with a history of hypertension is prescribed a new antihypertensive medication. The drug is primarily eliminated through renal excretion. The patient is known to have impaired renal function due to diabetic nephropathy. The physician decides to adjust the doses of the medication accordingly. Considering the patient's impaired renal function, how would the renal excretion of the antihypertensive drug most likely be affected? A. Increased renal excretion due to enhanced glomerular filtration. Unchanged renal excretion as the drug is not eliminated through the kidneys. Decreased renal excretion due to impaired glomerular filtration. Increased renal excretion due to tubular secretion. Decreased renal excretion due to reduced reabsorption. So decreased renal excretion due to impaired glomerular filtration. So in patients with impaired renal function, particularly in conditions like diabetic nephropathy, glomerular filtration may be compromised. As a result, drugs primarily eliminated through renal excretion, which relies on glomerular filtration, may experience decreased renal clearance. Increased renal excretion due to enhanced glomerular filtration. So impaired renal function is more likely to decrease rather than enhance the glomerular filtration. Option number B, that is the unchanged renal excretion as the drug is not eliminated through the kidneys. So if the drug is primarily eliminated through the kidneys, impaired renal function is likely to affect its clearance. Tubular separation may compensate for impaired glomerular filtration in some cases, but it is not the primary mechanism of most drugs eliminated through the kidney. Reduced reabsorption typically affects the drugs that undergo tubular reabsorption, which is not the primary concern in this scenario. So these are the factors affecting the renal excretion of drugs. So blood flow to the kidney, physiochemical properties of the drug itself, like molecular weight, lipid solubility, volume of distribution, binding character, and degree of ionization. Urine pH also alter the renal excretion of the drugs. The biological factor like age also alters it, and some disease states like diabetic nephropathy can have some effect. So again, the molecular size, so drugs with molecular weight less than 300 water soluble are excreted in kidney. Molecular weight 300 to 500 Dalton are excreted both through urine and bile. So the binding characteristics of the drugs. So drugs that are bound to plasma proteins behave as macromolecules and cannot be filtered through glomerulus. Only unbound or free drug appear in the glomerular filtrate. Protein-bound drug has long half-lives. Biological factor like age or sex, drug interaction also increase or decrease the factors affecting the disease state of urine pH and blood flow to the kidney. So talking about sodium, so the normal plasma sodium is 140 milliequivalent per liter, and the sodium is tightly regulated by renin-angiotensin-aldosterone system and antidiuretic hormone. The sodium intake is equals to the S2 retention. So sodium intake causes S2 retention. So sodium equals to 140 milliequivalent per liter. So if there is sodium loss, then there will be H2O excretion. So if the sodium becomes less than 140, then again there will be H2O excretion. The thing is that the sodium goes along with water, or you can say water follows sodium. So any drug that increases the sodium excretion will cause volume loss. Many diuretics will work by increased sodium excretion. So potassium is secreted by the distal tubule and collecting duct, and it varies with the sodium water delivery to the distal nephron. So if there's more urine flow, it will cause more secretion of potassium. So most diuretics will lead to hypokalemia. So most diuretics will cause increased sodium excretion. The water will follow sodium, so there will be more water excretion. So if there is more water excretion, means there is more urine flow, which will cause more secretion of potassium, and ultimately most diuretics will cause hypokalemia. Now, these are the simple basic concepts. Okay, so it was the renal blood flow, renal plasma flow, renal clearance. Okay, and now so the renal blood flow equals to the renal plasma flow by 1 minus hematocrit. Okay, so the normal renal blood flow is 1000 to 1200 ml per minute, and the renal plasma flow comes out to be 550 to 690 ml per minute. So talking about the renal clearance, so it indicates whether a substance is filtered, reabsorbed, and or secreted. So the fixed principle says that amount of a substance that enters the kidney is equal to the amount of substance that leaves it. So renal artery equals to renal vein plus ureter. So the amount from the renal artery that is entering equals to renal vein plus amount that have gone into the ureter. So the renal clearance varies from 0% to 100%. So albumin has 0% of renal clearance. Glucose is completely reabsorbed until and unless it crosses the glucose threshold. The para-aminohippuric acid is 100% cleared from the kidney, and inulin is used to measure the GFR because it is filtered, it is not reabsorbed, and it is not secreted. But the PAS is filtered and secreted. The creatinine is how you measure the GFR clinically. It is somehow equals to the GFR, is disfiltered, and it is minimally secreted. It will overestimate the GFR by some points, but yeah, we can use it clinically to determine the GFR when we cannot administer the patient PAH or inulin. So the renal clearance equals to, so the renal clearance of PAS is equals to the effective renal plasma flow, that is the urine concentration of PAS into volume flow by the concentration of plasma PAS. So, for example, if we have the urine concentration of PAS 550 mg per 100 ml, and the urine flow rate is 1 ml per minute, and the plasma concentration is 1 mg per 100 ml, and hematocrit is 0.45, then the value comes out to be 550 ml per minute. That is the clearance of para-aminohippuric acid. Okay, and the renal blood flow is equals to the 1000 ml per minute. So the clinical correlation is that a GFR marker. So a substance with a clearance equal to GFR may be used to calculate the GFR of the patient. Its clearance can be clinically determined to evaluate the GFR kidney functioning. Creatinine is preferred because it is endogenous, it is produced by the body itself. So if the patient has some hypersensitivity, or we cannot administer PAS, if the patient has some condition of contraindication, then we have to go for the creatinine. Otherwise, PAH or we can say inulin is the best. So comparison of clearance of a substance with clearance of inulin. So inulin clearance is equals to the GFR equals to inulin clearance because it is only filtered, it is not reabsorbed or secreted. So inulin is first best. So if there is decreased inulin clearance, it means that the substance is reabsorbed by nephron tubules. Okay, if the clearance of the substance is more than inulin, it means that the substance is secreted by the nephron tubules. So please understand it. So for example, if there is any substance A, if the clearance of substance A equals to the inulin clearance, it means that the substance is only filtered, it is not reabsorbed, it is not secreted. For example, if the clearance of the substance is less than inulin clearance, this means that the substance is being reabsorbed. And also, if the clearance of the substance is more than inulin clearance, it means the substance is secreted by nephron tubules. So the application of renal clearance and kidney function. So inulin clearance can be used to estimate the GFR. PAS clearance can be used to estimate the renal plasma flow. The measurement of filtration fraction is GFR by renal plasma flow. So here you can calculate the uh, clearance of inulin by clearance of PAS, and then we can divide it, and then we can measure the filtration fraction. So the measurement of creatinine clearance somehow overestimates the GFR of the patient. So fixed principle we have all discussed, and the same figure it is here. So for example, here this substance which is being filtered and it is also being secreted. Substance this, substance Y is being reabsorbed but is not secreted. Okay, substance Z, all of it is being reabsorbed. Thank you for watching. Keep studying hard.